Kia ora, everyone. Thank you so much for joining us tonight. I'm really excited about the session that we've got tonight. My name's Chris. I'm a volunteer with Aotearoa Climate Action. Oh, I'm so sorry. What a terrible start. I'm a volunteer with Aotearoa COVID Action. I'll be hosting tonight's panel, but I'll be handing over very quickly to our three guests because I'm as keen as you are to hear from them. A brief introduction to us. We're people from all walks of life who believe that it's our responsibility to work together in ensuring a healthy and safe community for everyone. Tonight, please, if you've got questions, feel free to put them in the Q&A at the bottom if you're watching us on Zoom, or if you're on YouTube, you can also put them in the chat there and we'll forward them to our speakers. We've got such a friendly chat, so many highs in the chat already. I love this. It's so nice. Feel free to put your questions in at any time. We'll have a Q&A session at the end of the three presentations by the speaker, but if you want to start getting those questions ready for them, that's totally fine. And you're also welcome to use the comments as well. Of course, please do keep the comments and the questions on topic and respectful. We want to make this a safe space where we're respecting everyone that shows up here and we're respecting their privacy as well. We're streaming this live to YouTube where it'll be recorded. Please, of course, feel free to express your support for clean air in schools. If you hear a quote that really resonates with you, feel free to share that on whatever social media you're using to find us and to share things with others. Just before we jump into the webinar, I just wanted to flag that we want to make this a safe space for learning. And the reason I say this is, as we all know, unfortunately, COVID has become quite politicized, quite a charged topic. We're offering this information tonight, without any judgment, without wanting to say anything about the way people have been behaving or anything like that. It's really here in the spirit of sharing information and enabling people to make informed choices about their health and the health of their family. Some of this information might be new to you, might even be surprising. So if you do find yourself during the webinar go, wow, I had no idea that COVID was this serious, or I had no idea that I should be taking, more steps to protect myself or my family, I would just say, go check out our previous webinar. It's a great place to go if you're looking for things to do. If you have that feeling of, gosh, I need to do something now. We had two great speakers talking about interventions in their schools. So a great place to go if you're feeling like you need to do something. So tonight we have three speakers: Dr. Amanda Kvalsvig, Dr. Espeth Fracatore, and Conor Brown. We've got 15 minutes for each of them to talk. After that, we've got 15 minutes for questions and answers. And then we've got 10 minutes at the moment where we'll just be sharing and reiterating some tips we've shared at our previous webinars about finding like-minded people in your community and taking action and the most effective ways you can create change in your community. So that brings us to our first speaker, which I'm very excited to introduce. Dr. Amanda Kvalsvig has a dual background in clinical pediatrics and epidemiology and is a research associate professor in the Department of Public Health at the University of Otago, Wellington. Thank you so much for joining us tonight, Dr. Kvalsvig.
Kia ora and hello to everybody. It's lovely to be here and thank you very much for inviting me. I think we've got a lot to get through, so I'm going to start sharing my screen. Oh, sorry, Chris, you're going to need to stop. There we go. One moment. Right. I'm going to talk about protecting the pandemic generation. And this is the generation of people who are children now, and they have many decades of life ahead of them. What do we need to be thinking about? I'm sorry, I've got a problem moving my slides forward. Apologies. I'm just going to stop sharing and start again. Just going to fix this for us. Let's try again. Let's see if that's no. Right. It's just, sorry, apologies, everybody. It just seems to be working through, and I'm not managing to move my slides forward. Chris, do you have any idea why that is happening?
Sorry, Amanda, I'm not sure why that would be.
Unusual problem. Let's just see.
We could go through them, just not in slideshow mode.
Yes, maybe I'll do that. Let's try that. Sorry, everybody, to keep you waiting. Let's right. So not an optimal solution, but let's keep this moving. Talking about protecting the pandemic generation, and the structure of this talk. I'm going to talk about what we know, and then, given what we know, what should we do? When we've got a new pathogen in town, a new disease in town, there are 4 key principles that we need to think about in terms of assessing the risk. And the first one is perhaps the most important. It's about being proactive, not reactive in assessing risk. We know that all serious infections, whether they're pandemic, epidemic, or endemic, have the potential to cause longer term harms. They all do this. So this should be our base assumption when we've got a new pandemic. We know that there are going to be longer term impacts. The real question is, what are they? How common are they going to be? What should we do about it? And so that is a very strong argument for a precautionary approach. We know that pandemics cast long shadows. We've had now enough time to observe the after effects of the 1918 influenza pandemic to know that the impacts for some survivors were lifelong. Our first coronavirus pandemic of the 21st century was the 2003 one. We've now had 2 decades to observe that one. The pandemic is over, but the long-term impacts on survivors are still going on today. So COVID-19 is really a baby pandemic. We're only 3 years into it. We shouldn't make any assumptions until we know a little bit more, until more time has gone by, that the effects are going to disappear. The second point I'd like to emphasize is listen to the lived experience of children and their families. And as someone who used to be in clinical pediatrics, that is rule 1, 2, and 3 of pediatrics. Always listen. Parents know when things aren't right with their children, and children know when things aren't right with themselves. They may not be able to articulate it, but they can show it, and we need to pay attention to that. Other speakers are speaking. Elspeth after me is going to speak about long COVID, and I think there have been other sessions about this. So this is a topic that's very important. I'm not going to dwell on it in this talk, just to say that we do understand that there are high impacts on some children and their families. And the biggest experts at the moment are children and their families. The third point is when a virus shows you what it can do, believe it. And what I mean by that is we now have the tools to assess impact of a virus without having to wait to observe them. So by looking at tissue and cell level effects, it's our version of a crystal ball. We can look at those effects to understand what future impacts on health might be. And that is a tremendous advantage that we have. This is no longer a completely new pathogen. There has been a lot of work done, and we actually understand quite a lot about the mechanisms of how COVID-19 affects health. And looking at those 5 different types of mechanism that you can see in that slide there from a very good paper, each one of those is concerning. So if we had just one of those 5, any one of those 5, we would be concerned about this infection. to have those 5 and actually some more emerging at the moment really underlines to us that we need to take this infection very seriously. The 4th point is one about impact in the whole population. So not just for one child or one family, but looking at this whole generation. Now we're broadening out the scope. Effects become frequent when every child gets the infection. So even something that's a relatively low percentage risk, when it's happening to every child, that means a lot of children are going to be experiencing that particular outcome. And COVID-19 is unique in the pathogens that the infections that children are getting, in that it's got this ongoing reinfection. And I just want to emphasize that point really. We don't have anything else at the moment that does that causes 2 to 3 infections a year. Even influenza, even flu, an adult would expect to get flu maybe twice in a decade, proper flu. And likewise, children might seem to have a lot of coughs and colds, but it's not the same infection each time. It would be a different virus usually. So this is really unusual, and that means that we need to pay attention to this virus. So you could see how it multiplies out. Most children are going to get COVID because it's so infectious. So unless we stop it, of course. They might not just get one infection, but multiple infections going forward in the years to come. And a high percentage of those infections are causing longer term effects, which might last just a short while, or they might last longer. When you put all that together, all those multipliers together, you get frequent health impacts. You get a big impact on that pandemic generation. And looking at what we know in Aotearoa, New Zealand, we don't even really know the full total of children who got COVID last year, because they weren't really being tested and it wasn't really being counted very well. But in the Kiwis cohort, 2/3 of the 5 to 9-year-olds in that cohort tested positive between February and September last year. That's huge. So until the beginning of 2022, very few New Zealand children had had COVID. By the end of 2022, most had. In terms of, people are often asking what percentage of children will get long COVID, what percentage of children will experience particular outcomes. And that's actually a very hard question to answer. But I just want to point out a very hot off the press, very recent results from the CLOCK study, which in that study, they found 12 to 16% of children with Omicron met the research definition of long COVID. So 3 and 6 months after infection. That's a lot. That's actually higher than some other studies. So what will the answer be for us here, for Aotearoa, for children who had Omicron last year? We don't know, and my colleagues and I have a study going at the moment to look at that. But we do expect that it will be a lot of children. So just to recap, we need to be proactive, not reactive in assessing risk. We mustn't wait for things to happen. We need to take a precautionary approach. We need to listen to the lived experience of children and their families. Absolutely self-evident. When a virus shows you what it can do, believe it. And what we are seeing come through is showing us that this is a serious infection. We must take it seriously. Effects become frequent when every child gets infection. So that this is thinking up at the population level now. We have a whole pandemic generation being exposed to this new infection, and we need to think about what we can do to protect them. So that's a lot of information about why we should be concerned. I also want to emphasize to you that we need to be hopeful and optimistic. We have so much going for us. Because of the elimination strategy, our pandemic started late. So most children in Aotearoa have had 1 or 2 infections. In overseas countries, they're looking at sometimes 5, 6, 7, 8 infections. We are still early in our pandemic, our own pandemic. We have time to act. We also have far more resources than in previous pandemics. This is really the first time that we've been able to do these very detailed risk assessments and understanding impacts before they happen. That's a huge advantage. And we also have better risk management tools. We have lots of tools for prevention and increasingly more for treatment. So we have that advantage too. So what we need to do in terms of building on these advantages that we have is we need to move out of crisis mode now. We need to accept that it's here, and we need to accept that there is a lot that we can do. And the first thing is clean the air. That's been discussed in other sessions, so I won't labour that point, but this is such a critical thing because it gives us protection against COVID, against RSV, against flu, the other viruses that children get, and the pandemics to come. This is a great, great place to start. We need to ensure that schools and early childhood centres are safe for everybody to access. This is about protecting learning as well as health. And above all, we need to build systems to protect people. This is not about using people to protect systems, and sometimes children have been used in that way. My colleague, Carmen Timur-Parata, has put this in a beautiful way, that we need to be placing a korowai, cloak of protection around our school environments and communities. We are saying that school should be one of the safest places a child can be, and that is an absolutely attainable goal. Earlier this year in March, we published an editorial, and I'm not going to talk through the findings. It's all there, and there's a lot of detail in there about making school one of the safest places a child can be. And we identified 7 goals, and again, that's all in the paper. There's one key point I want to make here, which is that the 7 goals are designed to work together, so that it's not a kind of menu where you can pick 1, 2, or 3 things. The goals are designed to work together. We're designing a system where every element has a part to play in supporting the other elements. And that needs really good strategic thinking to make that happen. So, last slide, you'll be here. How are we going to protect the pandemic generation? What do we know? Well, we know now that we need to prevent infection and reinfection, and we know how to do that. We need to build systems that protect people. So we need to move away from messages like enforcing attendance during a pandemic because being in school has become important. We need to move away from that. It is important that children are in school, but school must be safe. So we must always centre children and staff, families in what we do. Everything we do. We are building systems to protect people, and that is the heart of public health. Finally, we're still early in our pandemic. We can significantly, we can significantly limit its impact in the years to come, but we do need to start now. And thank you very much. That's it from me. I'm going to stop sharing and I'll move back to the main room.
Thank you so much, Dr. Kvalsvig. We'll move right along to Dr. Espeth Fracatore. Elspeth Fracatore is an emergency medicine physician working in Tamaki Makaurau after initially graduating from Glasgow University in the United Kingdom. She has a special interest in Manaki Mana, working to improve equity and outcomes for Maori patients requiring emergency department care. She's the founding member of Doctors Stand Up for Vaccination, a grassroots initiative founded in 2021 to create support for the vaccination effort against COVID-19. Dr. Frascatore, thank you so much for coming tonight.
Kia ora all. Please, I'm just getting into my screen share. We can have that awkward moment where we all wait for me to successfully share my screen. Please shout loudly if my slides are not moving for you. My name is Dr. Frascatore. I'm one of the ED doctor working in Auckland, as we've already said, and obviously worked in Auckland during the COVID outbreak. I've got a number of perspectives that come from my background in ED, working in the advocacy with regards to the vaccination campaign, and also as a person who has suffered long COVID. So we will cover a few of these things. One thing that can be said with absolute certainty is that Aotearoa was comparatively very good in a crisis. And from the point of view of the COVID outbreak in 2021 to 2022, and during the Delta outbreak, we did extremely well comparative to other countries with our lockdowns and making sure that we did not suffer the massive wave of the Delta outbreak like other countries did. So, you know, we need to remember that, and we certainly need to take that away. However, Aotearoa, along with pretty much every other country in the world, has proven itself to not be particularly good when the initial crisis is over. So on the left here, we have the number of COVID tests that have been done. And you can see that in after kind of January and early 2022, those test numbers just drastically dropped off. Not surprisingly, the COVID numbers drastically dropped off around about the same time, but then you're not going to know that COVID's there if you're not testing for it. So where it can certainly be said that those dangerous initial strains of Delta COVID are not so much around. It doesn't mean that another strain similar to that will not appear in the future, but they're not so much around. COVID very much still is around. And I personally take a bit of a personal affront when I hear people say that COVID is over, because it 100% isn't. The other graph on the right talks about vaccinations, and we can see that the first and second doses of the COVID vaccination were absolutely awesome, and rightly so, because the government pushed for them strongly, and there was large campaigns around them. But then as you get towards the first booster, the second booster, and the more recent boosters, you can see those numbers dropping off. Obviously, less people are eligible for the current boosters, but even when you take eligibility into account, the uptake of the boosters has significantly dropped off. So it's fair to say that probably the fear of COVID is decreasing, and that we're probably not doing as well as we could now that the, in inverted commas, crisis is over. From the point of view of the emergency department's experience of COVID, if you look across to other parts of the world and you see the experiences of America, the experiences of Italy in those early stages, the experiences were dreadful. There was horrible images of mortuaries and people having to deliver care in horrible circumstances. And that was not the case for Aotearoa. Because we were so good in that initial crisis, you could almost say that the department was at times quiet comparative to normal, even though you would never say the word quiet on the floors of an emergency department, because somebody would probably slap you, because we're not allowed to say that. It's a bad omen. But thereafter, those kind of quiet days very readily ramped back up to our normal business as usual, which I'm sure, as you can tell from media representation or people's personal experiences of emergency departments, is that we are very, very rarely quiet and very often extremely busy. And that is the case now. It would not be fair to say that COVID right now at this current time is impacting extremely strongly upon the emergency department or hospitals, because that just isn't the case. At any one time, you probably have 1 to 2 patients with COVID in the department, and we have upskilled in COVID, upskilled in our PPE, our personal protective equipment, upnumbered in our negative pressure rooms that suck the virus out through vents. And we're a lot better at COVID now than we were. But not everything is about COVID. COVID isn't the only respiratory virus out there. So you'll see it from this graph. I believe it's 2020 and 2021. But currently there's other windows in front of the right side of my screen. But if you look at the green and the purple line, you'll see that numbers of self-reported flu-like symptoms were extremely low during the years that we had lockdowns and COVID. you can see that the current years are much higher, much more like possibly normal numbers or possibly higher than normal numbers. You'll have heard bandied around the phrase immune weakness or immune holiday or immunity debt. And that term is used incorrectly sometimes. Apart from having chemotherapy or cancer, there is really no such thing as a strong or weak immune system. The immune system just is. The immune system just exists. And if it sees a virus, it will fight it and then develop some form of immunity to it. So what we're seeing now is that because we were in lockdown for, a significant chunk of time, viruses that would have propagated at that time did not, because people weren't having contact with each other. Now that we're having more contact again, we're not coming out with a weak immune systems. Our immune systems are the same as they have ever been, but they may not have seen viruses that they previously would have. Therefore, they're coming out naive to those viruses and having to develop immunity to them. So as a result of that, we are seeing some surges of viruses because people with perfectly normal immune systems are having to develop immunity to those viruses. So just to let people understand what that phrase means, it doesn't mean that people have weak immune systems because of the lockdowns. It just means that we are seeing viruses for the first time because we were in lockdown for a while. But what I think we need to, as a country, shift from is thinking about acute COVID. We keep thinking about the Delta wave, mortality, so how many people are dying, ICU beds, how many people are in intensive care, hospital admissions, and things like that. And that was relevant and the case during Delta. But currently, we need to be thinking more about the longer term implications of the COVID that we currently have. And the COVID that we currently have isn't making people very, very sick. I mean, it's making some people sick, but most people, it's just giving them a flu-like illness. But that is not the only thing that COVID can do. And what we need to be thinking more about is long COVID. So the current COVID that we've got, as I said, it's not putting people in hospital. It's not filling up our intensive care units, but that doesn't mean it's not significant and significant in the long term. I personally have had long COVID twice. I had long COVID for about 3 months after my first bout and about 4 months after my second bout. Now, when you put into theory 3 or 4 months, it doesn't sound like a lot, but if you catch COVID twice in a year, that's half of the year for you is gone. Long COVID is becoming better understood. And as a person who's had it, I've obviously done a fair amount of reading on it, which you'd find a lot of doctors don't actually have that knowledge. It's multifactorial, as Amanda pointed towards. The COVID is known to, rather than have COVID and then have it go away, instead, the COVID is known to stay on in people's organs. So it may stay on in the brain or may stay on in other organs. Now, that's not new. Chickenpox stays on in people's organs and can come back as shingles many years later. So that is not a brand new thing or a surprising thing for viruses to do. But the thing is with COVID, for a certain number of people, it can cause a kind of autoimmune response whereby your immune response to the COVID also can damage your own cells. And what we do know is that it can damage your blood vessel lining. And obviously blood vessels go all over your body to supply all of your organs. So damage to your blood vessel lining can be very concerning. It's also known very well to cause what's called microclots, so extremely small clots. And all of that put together can result in damage to the organs that COVID is affecting. One of the more recent pieces of research seems to suggest that the damage is actually something called a reperfusion injury, whereby if you're having not a great perfusion of an organ and then blood flows back into it, then that can actually be where the damage is caused. So all of this, because it's affecting multiple different parts of people's bodies, it can manifest itself differently. For me, it manifested as extreme fatigue, which is not new. We've all heard that before. But it also manifested as the brain fog, which we've all heard of before. Now, I don't like the phrase brain fog. It's very almost dismissive. I like to think of it more as a viral concussion because it has a lot of crossover with concussion. And in that, for me personally, I had a lot of different symptoms. And these are a lot of different symptoms. As I describe these, try to then translate them into children or learners' environment. So for me, I had a lot of problems with auditory processing. So an inability to have multiple conversations going on in a room and being able to localize out a specific conversation. I had difficulty with kind of executive level functioning. So complex decision-making or multi-step decision-making. I had difficulty with amnesia and inability to lay down short-term memory. I had word-finding difficulties. So rather than having conversations or the words that you think of just automatically come out of your mouth without having to think, instead for me, it was that you had to hear a conversation, decide what you're going to say after processing it, and then say it. So every part of the conversation became deliberate, and there was no automaticity to it. So for me, as a doctor, and I want to highlight that my work was incredible, they allowed me to return to work in such a way that there was never any risk to myself or any patients. But what was it that work had to do to allow me to do that? At first, I could only do 4-hour shifts and step up with that. At first, I couldn't supervise other doctors. I couldn't work in resus situations. I couldn't be in charge on the floor. And all over time, I was able to do this. But what's the impact on the rest of the workforce? So you're then having to have other doctors being able to fill in those gaps. If you then extrapolate that out to other professions, such as aviation, nursing, teaching, anywhere where you're having multiple inputs from multiple directions, then you're going to have a lot of areas that, as long COVID affects more and more people that are impacted upon from a workforce point of view. Then extrapolate that to the child or to the learner. If you're getting an episode of long COVID, even if it's only for 2 to 3 months in your formative years where you're laying down pathways, where you're trying to learn, where you're developing behaviors, what would be the impact of that upon a child? And how would they even recognize what was happening to them and be able to express that? And I think that is what we're not talking about as a country. We're not talking about workforce implications if you're having multiple teachers, university lecturers, engineers, if you're having a proportion of your workforce that is impacted by long COVID. And what's the impact upon our children? We know that children get long COVID. What are the psychological, physiological, physical implications of that? I think that there are no experts in long COVID in Aotearoa. There are hardly any experts in the world, to be honest. And we need to start listening to people who've experienced it and who can explain what the implications are so that we can make our response proportionate to the risk. The risk is not that lots of people are going to die. That's not the risk anymore. But there is a different risk. And I think that it's time that we started to talk about it. So thank you very much for listening to me. And I will stop my sharing.
Thank you, Dr. Frascatore. All right, we have our last panelist before Q&A. So that's Conor Brown. Conor Brown
Okay.
is a biorisk consultant. Oh, sorry, Conor.
That's okay.
I was just going to introduce you. He advises commercial organizations on the current and future risks posed by infectious pathogens, including but not limited to COVID-19. Thank you, Conor.
Thank you for having me, and thank you for those two wonderful presentations before. So I would just reiterate what Chris has just said. I do not come from the medical point of view on this particular topic. I come from a much more business, economic oriented position. I talk a lot about risk to clients. This is the first time that I've dealt with an educational setting, but some of the broader messages I think I'm going to give are just as applicable, to be honest. The first thing I'd like to say is that I'm speaking to you from Belfast, Northern Ireland. So we've actually been in our kind of the stage of the pandemic, the ongoing pandemic, for longer than you have. So we've seen a lot of these impacts that have been talked about by the previous two presenters kind of play out in real time. So I can assure you that a lot of what is being said, if you go forward a year or a year and a half, you're going to see these things start to manifest themselves in society. The first point I would make is, and again, drawing from a broader perspective, looking at this from a sort of a more top-down approach, that there is often a misconception in society, and certainly in politics, that we can take the ideas of public health, and in this particular case, the ideas of looking after our children and looking after our children in education, and somehow placing that in opposition with the idea of education. So on one hand, we have public health, and on the other hand, we have education. And also we see this as well with the idea that we have public health on one side and the economy on the other. And a lot of the political discourse, a lot of the educational discourse that has been going on in this country and the UK, is that somehow that these two ideas are in conflict with one another, that somehow the ideas of public health are in conflict with the ideas of education, or the ideas, for that matter, of public health are in conflict with the ideas of the economy. Now, one thing that I often try to get across to clients is that this is a completely and utterly false dichotomy. That you cannot you do not place the idea of children being in school, children receiving a good education, somehow in conflict with the ideas of public health. And just to break that down very basically, and as has been talked about by previous presenters, one of the things that I think has been lost, and especially in a lot of the discourse, sadly, in the United Kingdom, is that we are entering a position with education where we are basically forgetting as a society here that for children to learn well, for teachers to teach well, their health must be paramount. And as one of the previous panelists talked about, their safety must be paramount. So in other words, to create a productive, safe, and efficient learning environment, you want to really make sure that the staff in the school, the teachers, everyone who works there, and all of the students, all of the children are all as healthy as they can possibly be. And I know we've been talking about that exact topic thus far, but it's something that I suppose this is a warning from further down the line, because this is the way that politics has shifted in the United Kingdom to a culture of presenteeism above all costs. The idea that children just have to be in school, and we have very, very few mitigations here. So the thing I would say is that one of the previous panelists alluded to this as well, that you're in a very good position, because you're in a position to be able to address this risk right now and actually move forward. So the first thing I would say, just talking about children in school, is that there is no contradiction between having a safe environment for people to learn and the ability for people to learn. Basically, there is no conflict between education and public health, and unfortunately, that has very much seeped into the discourse in the United Kingdom, where somehow these two things are set apart. They are set as if they're in conflict with one another. The other thing I would say is to remember, and I would also reiterate this with the economy as well, because you will hear a lot of arguments like this as well, that somehow elements of the economy are somehow in contradiction or in conflict with the diktats of public health. This is absolutely not the case. Health is paramount for all of these things, and this sounds very much like stating the obvious, but unfortunately, I've had to state the obvious for about the past year and a half, and I just want to make this very clear. So if you want to have a good learning environment for children, if you want to have a safe learning environment for children, and you want to have an environment where children learn as best as they possibly can, you want to have an environment that is safe, and you want to encourage the health of students, staff, and every other learner. Now, as was previously mentioned, we are seeing these very concerning studies regarding long COVID in children. And as the previous panelist pointed out very clearly, one of the things that we've seen, and we see this not only in children but in adults as well, the executive dysfunction that can be caused by long COVID is a significant impediment to learning. It's a significant impediment to the whenever anyone is doing a skilled task, you will see that there are all kinds of problems that start to flag up as a result of that. And I think one of the basic points, just trying to stay fixed on education for the moment, is that if you have children who are suffering from long COVID, and we know that children unfortunately are quite prone to getting long COVID after each infection, you create a situation where a child is less able to learn anywhere near as effectively as the child could learn if the child did not have long COVID, because of these neurocognitive effects that we tend to get, this brain fog. And by the way, I agree, I don't like that expression either. I don't like the expression brain fog. I think it tends to minimize the problem a little bit. So there's a lot of reasons why keeping our schools safe, keeping educational facilities safe in terms of, and when I say safe, what I mean is minimizing the amount of transmission that occurs in those schools. That is not only a very good idea, but it is in no way, it doesn't conflict in any way with the idea of having a good education for your children. Quite the opposite. It is something that is a necessity for having a good education for your children. And the reason that I suppose I keep pushing this point is that I'm aware that, as I said, you're earlier on in your pandemic than we are. And I've seen very clearly here how the discourse has moved forward into almost placing these things in opposition. So I think that's probably the first thing to remember, is that having safe environments for children to learn is essential for children's education. That there is no conflict between the two. That may sound like stating the obvious, but as I said, politics can move in quite malignant ways with this particular idea. The second thing I would like to draw your attention to is, and this is one of the ways that I would probably describe it, is never ever think about the idea of COVID transmitting and it stopping at the school gates. What we know, and this is something that we've learned the hard way over the past couple of years, is that schools and educational facilities in general are centers of transmission for the virus that will spread out into the community. So when you start taking this slightly more broad picture, making schools safe is not just about the education of your children. It's not just about that, because the virus doesn't respect the gates of the school. The virus will go further into the community. So and you can get what are referred to as chains of transmission. So in other words, a child, and some of you may have experienced this already, where a child comes home and infects people in the household, and then you get a kind of a cascade effect, where maybe an adult in the household gets quite ill with COVID, maybe gets some long-term effects, and then isn't able to work for 2 or 3 months. So what you see is a wider spread that goes beyond not just the education of children, but moves into having adverse effects on the local economy, because you've got people who can't work, people who are too unwell to work. Now, all of this kind of, it's a kind of a holistic approach. You can never really think about this virus purely based in one location. So I suppose what I'm trying to get across is that keeping schools safe is very, very important in terms of the education of children, and obviously, of course, for keeping the staff and the teachers safe. But it also serves another more important function, which is basically that schools themselves tend to drive community transmission in whatever community that they're based in. So in other words, if you have high transmission in a school, if a lot of kids are getting COVID or are getting COVID in the school, then what's going to happen is that's going to raise levels of COVID in the community, which can affect, as I said, can affect the local economy, and can also, sadly, these chains of transmission can eventually end up with a vulnerable person or someone who's immunocompromised, and then you start getting people getting really ill. So I think probably the way to think about this quite holistically, and this is how I try to approach it from a business point of view, is there is never, first of all, there is, as to reiterate my first point, there is no conflict between making schools safe and the idea of having an education for your child. Quite the opposite. It's making schools safe is a prerequisite for having a good education for a child. Second of all, there is no conflict between mitigation measures for COVID-19 and somehow these mitigation measures adversely affecting the economy. Quite the opposite. That's very, very short-term thinking. Having good mitigation measures in place, reducing the transmission of the virus in the community is actually exceptionally good for the economy. It's exceptionally good for pretty much all aspects of business. And again, this is something that I constantly try to get across to my clients. One of the things I would say, just picking up on something that the previous panelists said, the issues that arise from long COVID. Specifically, these ideas of a degree of cognitive dysfunction, this brain fog that has been alluded to. We are starting to see evidence that this is actually starting to have it's quite significant real world impacts in countries that have had essentially uncontrolled transmission of COVID for a couple of years, like the UK, like the United States. What we see, for example, is quite a significant increase in road traffic accidents. So even using that as an example, and this is where we again think about the idea of the virus itself and transmission of the virus moving beyond the gates of the school. You can imagine, for example, if someone who's a bus driver who has got long COVID and is suffering from executive or cognitive dysfunction, then that person will be less able to drive a bus and to take the due care and attention that one would expect in that particular profession. We have seen it in the United States, this effect kind of rearing its head, I think, in air traffic controllers. The Federal Aviation Authority in the United States had to have one of its very first emergency meetings earlier in this year because air traffic controllers, there were so many near misses that the FAA had to call a meeting. So this particular type of long-term effect, this cognitive dysfunction, whether it lasts a month, whether it lasts 2 months, whether it lasts 3 months, perhaps even longer, it's pernicious in lots of different ways in society. Basically, any profession that involves skilled work and any profession that involves having to think very quickly, having to think and act very quickly, is starting to be affected by people who unfortunately are having to turn up for work with this brain fog. So I think to kind of sum up what I'm saying from this kind of larger sort of top-down approach, first of all, again, no conflict between public health and education. The two are exactly the same. You cannot have good education for your children without healthy children and healthy staff in the school. Second of all, never ever think that what happens in a school stops at the school gates. That the transmission can occur. Schools are hotbeds of transmission in the entire community. And if you can lower the rates of transmission in a school, you will lower the rates of transmission in general throughout your entire community, which is good from a business point of view in the sense that less people get ill. And it's also good simply from the point of view of less people will get sick. Because as I said, a chain of transmission can easily happen where a kid gets sick, that the virus is brought back to someone at home, someone is vulnerable, and that vulnerable person or immunocompromised person ends up in hospital. So there really is no downside to mitigating the transmission of virus in school or learning environments. And I suppose I would end with a note of caution, because there's a degree of it almost feels like time travel here, because I'm in a country where there has been little to no mitigations done for a very, very, very long time in terms of the duration of the pandemic. And we are seeing the effects that the previous two panelists have talked about all too clearly. We are seeing children that are sick a lot of the time. We are seeing teachers who are having difficulty teaching because they've got brain fog. We are seeing a general reduction in quality of education because no mitigations have been put in place. And I realize from what has been talked about before that you've had previous webinars about mitigations in schools. One of the things that I would just emphasize is that cleaning the air is so important. It's a very easy intervention. It's a low cost intervention. And it's something that I think really we need to, especially in New Zealand, because you now have the time to do that. You have the time to act and get these things in place, that I think you really should consider doing that in absolutely every school you have. The thing to remember, and I'm just aware of time here, but the other thing to remember about risk is that never ever forget that no mitigation strategy is 100% effective. So in other words, even if you kit out an entire school with air cleaning, you will still get cases of the virus. That's going to happen. So never think about risk in binary terms. Something works or it doesn't. What you tend to find with this particular virus is you can reduce the transmission a lot. And one of the sayings in public health is that you never really see what happens whenever something works, because what you're seeing is you might see two or three infections in the school and think, oh, these systems aren't working. But of course, what I would say to you is that if these systems are in place, you might be seeing 15, 16, 17 infections. So it's always about thinking about risk in terms of gradient, in that you can reduce it and you can use different layers to reduce it. But that is a key thing. If you can reduce transmission in schools, you can create a better environment for teachers, for education, and for your communities in general. And I think that's probably a good place to leave it. Thank you very much indeed.
Thank you very much, Conor. So we've got a few questions coming in, and I know our panelists have been at work answering some of them already. And if they continue coming at the rate that they have been, then we'll have quite a few. We might not get through all of them, but we will take note of them, and we'll see if we can get you some answers somehow, maybe later in the evening or something like that, if we're unable to get through all of them tonight. I did want to take host's prerogative and kick off with a question. And that question, I just wanted to hark back to the statistics that Amanda shared, which just absolutely blow my mind, which is, if I'm reading it right, at the bottom of one of the slides, it said that every infection carries a risk of between 1 in 6 and 1 in 8, it seemed, children getting long COVID. It was somewhere around like 12, 16%, if I remember right. And that just seems so high, because almost everyone I know has had COVID, and yet I don't feel like I know 1 in 8 kids that have long COVID. And so I was wondering if perhaps Amanda or Conor, you could talk to, like, why do we, I'm sure I'm not the only one who experiences this feeling of like, we feel like it's a different reality, like this, like our sense of this is off. We feel like we're overreacting when we see these statistics and when we don't see them outside. Amanda, you put up your hand. I'd love to hear your thoughts on that.
Yes, thank you. This has been so conflicted, trying to nail down an exact percentage, and different studies will give you different answers. And this study, I think, is quite interesting because some of the authors of that study have in the past been quite dismissive of long COVID, and now they're coming out saying they found a high percentage in their cohort that they were studying. You might find another group of children that have a lower percentage of using the same definition, but they might have a lower percentage. I think it is a little bit of a deflection strategy sometimes when people say, well, we just don't know enough, and the studies contradict one another as an excuse to do nothing. And I think we need to be really careful about that. The fact that we have this lived experience coming through, and what Conor is describing now as proper population level effects starting to come through into daily life, and we know enough to know that we should be taking action. We shouldn't wait for it to coalesce around a specific number. And that was just the first point. And sorry, there was another one I was going to say that study that I quoted is quite small, so the variation is quite wide. So we need to be a little bit cautious, but it was very robust and was very carefully done. So, so I think we should take note of that study.
Can I just add something to that, if you don't mind? The one thing I would add as well is that, Amanda, you mentioned the importance of lived experience. And this is something that I have found quite often in my work, is that people will, whenever you get a chance to actually talk to parents about their children, you will often find that after talking to them a little while, they will say something isn't quite right with my child. So I don't think that, I think sometimes that goes away to explaining why people think, oh, well, this seems like a very, very high number or a very high percentage, but it's because often long COVID can be quite hidden. It can be something that isn't particularly obvious to outside people, but whenever you actually know the child or you know the family, often you will hear things like, my son hasn't been quite right since the second infection or something like that. So I think it's probably quite hidden in some cases.
And just to add one final thing is that I have to tell you that the gaslighting is real in this realm. The amount of times that I've spoken about what I've experienced and know it to be real, then you can see in other people's eyes the disbelief and the gaslighting and the suggestion of a concrete pill, and the suggestion that perhaps it's just menopause. So I think that we need to be real with the fact that there's a lot of long COVID that's happening under the surfaces that no one's talking about as well.
Thank you, everyone. All right, I'm going to do my best to try and choose some questions that that people on the panel can speak to, and that we'll be able to get worthwhile answers here tonight. Maybe if I could start with this question: are there any insights into Australia's long COVID clinics and outcomes versus New Zealand's lack of clinics, and how long COVID is being handled by GPs or specialists? Dr. Frascatore, I saw you nod, so maybe you could jump in.
The problem is, I don't think anyone is qualified to answer that question. There are long COVID clinics in other countries. There's also a hell of a lot of long COVID grifters out there. There's a lot of vitamin infusions, saline infusions. If you throw enough things at somebody, then they might work. But in the end, is it just time that is the healing factor? So there are genuine ways that long COVID clinics can help, which would need to be affiliated strongly with existing medical services and hospitals. And it is a minefield for the grifters. By grifters, sorry, I just to translate that, I mean people who are offering a fix that is often expensive and not evidence-based.
Thank you. Sorry, I wasn't sure if the others wanted to add.
I would add one point to that, Chris. One of the most disturbing things that we saw in Ireland, I'm talking about the Republic of Ireland, not the UK, was the gradual defunding of long COVID clinics. So again, this is this kind of looking forward in terms of we've been dealing with this for longer than you guys have, and it's kind of like a warning of what can happen. That there has been and again, this harkens back to something that was just said earlier. There is some elements where the gaslighting is actually so strong that it's become institutionalized, and that you actually see, sadly, you see government incentives to almost push long COVID to the sidelines. Now, obviously, anybody who has experience with ableism and things like that will recognize where this is coming from. But it's terrifying to see it on a governmental level in the health service, where these things are actually trying to be they're it's not just that they're being treated at a minimal level. It almost feels sometimes like they're being pushed away. And that's something that I would just caution you. I would caution you, because it is a terrifying thing to watch. So whenever the previous panelist said the gaslighting is strong, I assure you she is absolutely correct. It is very, very strong indeed.
Yep, Amanda, did you want to add something?
Just to add a very quick comment that you'll hear pediatricians say, well, I never see any cases of long COVID. And what they're really telling you is, firstly, they're telling you about how the health system works, because people have to jump through so many hoops to get to see a specialist that often they don't. So they don't get believed at the first hoop, they will never get to see the pediatrician. And the second point is, sadly, if somebody's telling you that they know nobody with long COVID, what they're probably telling you is that they're not really a safe person to disclose that experience to. And so you find this, some people know about lots of long COVID kids, and some people don't know about any. And that there are reasons for that, sort of structural reasons for that, if you like.
Thank you. There's been a couple of questions in the chat about getting people to listen, I guess, is the common theme there. But we might start with this one, because a couple of them have been directed to you, Conor. So, for example, one that's just asked, have you had the businesses you talked to responded to your advice and recommendations, and are they taking action? And then the next question below that also, like, these arguments have been lost in the UK, how can we win them in New Zealand?
Yeah, so first of all, a lot of businesses do actually listen to my advice and put certain things into operation. That's, I mean, I work with companies all over the world, and some will take the advice and some will not. They hire me for the advice. Whether they actually put it into action is very much their decision or not. Certainly from the very beginning of the pandemic, when I was working in a more of a business continuity space, and this was whenever things were very bad. This was before vaccines. Lots of companies were putting business continuity plans into place. What has happened, unfortunately, and again, this is something that harkens back to what other panelists have talked about, is that because there is this feeling that we are no longer in a pandemic, in fact, a lot of companies, some things have kind of slipped because they feel like there's no need for any necessity for any of this. But the other thing I would say is that companies certainly have instituted things like air cleaning and things like that. That is happening, and I think I would add a note of optimism to that there is more of that happening, I think, than people imagine. You will often see, you'll often see pictures of office buildings, and suddenly there's lots of HEPA filters have kind of appeared. So there is a kind of an underground movement. It's not huge, but it is happening. Could you remind me of the second question, Chris, just so I could?
Oh, it was much along the same lines. It was like, these arguments have been lost in the UK. How can we win them in New Zealand?
Well, first of all, I think they've been lost temporarily in the UK. I don't think they're going to be lost forever, because and I think these two ideas fit together, because one of the ways I would say you win the argument in New Zealand is you look at the situation in the United Kingdom and you say, do you want to be like that? I mean, that's very much the way I would put it. We have had the United Kingdom has the highest number of people out of work due to disability since, I think, the previous 15 or 16 years. Don't quote me exactly, but this is the government has tried to spin this in lots of different ways, but quite frankly, it's very, very highly likely that a lot of it is due to the fact of long-term effects of COVID. So whenever you start seeing significant workforce problems as a result of long-term effects of COVID, then governments eventually have to take some kind of an approach to this, and I think that's happening in both the UK and the United States. One thing that just to end on that point, there is a reason that throughout the entire of the pandemic, the best reporting in the UK and the US and other parts of the world, the best reporting on the pandemic has been in the financial press. And that often surprises people, but it's magazines like Forbes, Fortune, the Financial Times, because there is that recognition that if you let this thing continue to burn through society, you eventually leave this tail of disability that becomes unsustainable economically. And I think countries are gradually starting to come around to that. So I would say the way you win the battle in New Zealand is you look at what's happening in the United Kingdom and other parts of Europe, and you say, we are not going to be like that, because that will actually give your country an economic advantage. And that's the way I would frame it if I was talking to policymakers.
Thank you. Did any, Amanda or Dr. Frascatore, sorry, Dr. Kvalsvig, did you want to add anything to that?
I would just say we're happy to learn anything we can from your experience. You are the time travelers, Conor, and so anything you can tell us. We are trying a lot of things, so we're not sitting around. And we have been aware from the very beginning that when we look at countries outside New Zealand, we're looking into our own future, and so we are aware of it. But being able to look ahead is very helpful, because we can communicate that to policymakers, and we do.
Thank you. Another question here. Why are vaccinations not being more encouraged for children?
I think Amanda would be best to answer that.
Fine. I will answer and say that I am not aware of all the discussions that have been made in making vaccine decisions at a country level. I'm aware of some of them. I do think there has been some underestimation of, firstly, the importance of the value of vaccination for children, and perhaps secondly, the willingness of parents to take up vaccination. So we would never advocate for any kind of mandated vaccination for young children. But what my colleagues and I are asking for is for parents to have the choice. It's been very well looked at in the US and other places. These vaccines are very well studied. We know that outcomes for children are better when they've been vaccinated compared with when they have the infection and aren't vaccinated. We know that it's very, very clear. So we want parents to have that option now. And it's unclear why New Zealand has been so slow to make vaccines eligible. And that's particularly a problem for our Maori and Pacific populations. These are the people who are most at risk, and they need to have that option as a key equity option.
Thank you. We might move on to another question as we're running out of time. We've got a question here about air filtration. This might be one for Dr. Kvalsvig and maybe Conor, in your experience. How many times should the air be changed per hour? Does the number of times change as a function of the number of people or children in a room?
Okay, so I can take that. I would stress I'm not an indoor air quality expert, but the kind of the received wisdom for this so far. So first of all, ideally, you want to change the air in a room 8 times per hour. That's a good figure for having a very, very low rate of transmission. The CDC, quite surprisingly, actually, a few days ago, released guidelines. They put the number of air changes per hour at 5. And I think another professional organization yesterday set it at about 6. We tend to think that 8 is ideal. So the idea is that you basically change the entire volume of the air in a room 8 times every hour. You ask the question, does it matter how many people are in the room? The answer is not really, because what you're doing is you're changing the volume of air. And the way to think about why this works is, and again, I'm sure you've covered this in previous webinars, is the way to think about the transmission of COVID is to think about the SARS-CoV-2 virus moving in the air as if it was invisible cigarette smoke. So that's the way to think of transmission, right? You don't think about droplets. You don't think about these 6 feet arbitrary rules. You think about it moving like cigarette smoke. If you can keep changing the air in the room, you're pulling that smoke or that viral smoke out of the atmosphere of the room, and thus reducing transmission. But I would say if you want optimal air change, I would say 8 times per hour.
Thank you. Amanda, did you want to add?
I'll just say something quickly about our situation here with New Zealand schools. School buildings are generally poor quality. In New Zealand, they're poorly ventilated. They often rely on opening windows, so they don't have mechanical ventilation. So it can be hard to achieve those high standards. But I think it's really important that we have those standards and articulate them and say, this is the goal. This is what we're moving towards. We may not be able to do that today, but that is what we want for children on into the future, because this is a permanent change in how we think about children's health and about the air that they breathe. We never want to go back to a situation where children are breathing dirty air full of viruses. We're never going to stop and say, right, it's time to stop cleaning the air and everybody go back to breathing dirty air again. We're never going to do this. This is a pandemic legacy that we have. We want to make that an ongoing change. And if we think about it that way, we can think about ourselves as working towards that goal, even if we can't do that right away.
If I could just add something, somebody asked previously on the questions of, are hospitals safe? And am I likely to catch COVID if I go to a hospital? And the fact is that probably one of the least likely places to catch COVID is ironically a hospital. One of the most likely places is a school. I don't have the graph to hand, but we recently Aotearoa released a graph of professions and risk of COVID within professions. And right up at the top was teachers. And 1/3 of the way down the list was doctors and nurses. So I think we need the risk right now is it's not actually in the hospitals, it's in the schools.
Childcare was number 2, by the way. So that really tells you about the state of our air, where children are and where their carers are.
Thank you. That's actually a great segue for me to plug our last webinar, where we did show that graph in the webinar. That's all the time we have for questions. There are still questions there. As I said, we'll take note of these questions and we'll see if we can get some answers to them. I know not all of them are quite within the realm of, within the scope of our panelists' work. But I want to thank our panelists again. Thank you so much, Dr. Amanda Kvalsvig, Dr. Espeth Fracatore, and Conor Brown. I'm really grateful that you were able to give your time tonight to share your expertise with everyone. Thank you so much.
Also, I'd like to commend Mr. Conor Brown for having the only pronounceable name, and apologise for my name and Amanda Kvalsvig's name. You've done very well.
I think that's
Chris.
my cue to apologise for my pronunciation.
You've done very well, Chris.
I answer to anything. I'm very used to it. It's a Norwegian name and English speakers can't say it. So there we are.
All right. So just to wrap up tonight's session, we have just a quick revisit of some of a topic that a lot of people are asking about in the questions. So, excuse that. A question that comes up again and again is, how do we make this change happen here or in our schools? And we don't purport to have all the answers here, but we have talked about this in previous webinars, and we know that it's a question that's at the forefront of everyone's minds. We just wanted to spend a little bit of time before we wrap up the webinar recapping some of the key points. If you're feeling compelled to take action now, these are some steps that you can take. So firstly, like, a well-informed community is a healthy community. That's why we're running these webinars, is so that more people can understand the risks and the impacts and the action that they can take. Our previous webinar, you can find it if you go to covidaction.nz/health. There's a recording there with I'll show you on the next slide, shall I? With Dr. Andrew Dixon and Oliver Zeiler, talking about some interventions that they've done in their schools. It's a very worthwhile presentation from both of them, talking about the different things. If you want the cheat sheet of what they talked about super briefly, again, it came back to like the 3 interventions that you've heard the speakers talk about tonight, being masks, air, and then cleaning the air, whether it's by filtration or by mechanical ventilation. And there's like a few pro cons there to think about, but really any of these, are worth considering and worth thinking about how you can get one or more of these happening. If you're going to be advocating in your school for change, then one of the key things that we've been coming back to, and a reason for organizing these webinars, is that you want more people with you. It's very hard to push for change on your own. The good news is that it doesn't have to be a majority of people in your community. So social change theories, various theories tell us that we need only a minority percentage of people actively moving for change. So it could be 2, it could be 3, for example. And this example is if you've got a group of 12, say, for example, a board of trustees, if you can find 2 or 3 people in that group to actively advocate for change, and the key there is actively, not passively, but if they're speaking up, then you have a really, really good chance of shifting that group. The other thing to think about is your trusted pathway to decision makers. Right? It's very tempting to go straight to the principal, straight to people with decision-making powers, but it's worthwhile stepping back and thinking about, well, who are the people that they're relying on to get their information to make their decisions, and where do the trust networks lie? Who are people who listen to you and take your, the things that you have to say seriously, and where's the connection between those two? Again, it increases your chances of making an impact and of changing minds. And the last thing to think about is just thinking about all the places that you can find allies at a school, really thinking through all the different clubs, societies, the different roles inside of a school and their concerns, whether it's union representatives. I saw someone ask about union representatives in the chat. Heads of departments, parents, students with vulnerable family members. If the students are volunteering with a society that works with vulnerable members of the community, they probably have a vested interest in reducing transmission in school. So think about all the potential allies that you could find in your school, put yourself in their shoes and ask yourself why they would want to collaborate with you. They may not be aligned 100%, but there may be opportunities to find alignment. And what we ask at every webinar, give some thought to that. Find 2 people you want to bring to the next webinar. I'm so grateful to the people who have obviously done this between the last webinar and now, because we've doubled the number of people that are attending today, which is fantastic. And if we can keep doing that, then we build the support in our community for this action to take place sooner rather than later. So with that, I just want to do a quick plug for our next talk about talking health and making change in your community. We've got 3 speakers. We've got a parent who's going to be sharing how they've moved their board of trustees to take action on something that the board of trustees required a little bit of work to move them on that. So I think that's just such a great example and so valuable for so many of us that are banging our heads against brick walls on this. We've also got a science communicator coming to share, and we've got someone again from overseas coming to share some examples of where things have gone right and where things have gone wrong. Really excited to be sharing this webinar. Like I say, try and get at least 2 people to come along to that webinar. The more people you can find, then you don't have to be going at this alone. And this is a much easier piece of work to be doing in your community when you're not doing it by yourself. As someone who's had to advocate for change in other areas, as you may have heard by my slip of the tongue at the start, it's really, it's not only easier, but it's much more enjoyable when you're doing it with someone else, with someone who shares your concern, who shares your values. So think about stones you haven't turned over yet in finding allies in your community and why they might be willing to work with you. Thanks so much for coming. Thanks so much for inviting your friends along tonight. It's really, I know everyone in our community is so excited to see how many people have been coming along tonight. And we hope to see that again at the next webinar. And we hope eventually to hear stories of success in your community. thanks so much for joining us.